Welcome to the Trauma Series 12. So today we are going to discuss about trauma in pregnancy. So pregnancy, our priority is first the mother, then the fetus, and early involvement of surgeon as well as obstetrician is a general role in trauma in pregnancy. To 12 weeks, the uterus is going to be intrapelvic. Then 24 weeks, it is going to be at the umbilicus and the sternum by 34 weeks. And after 34 to 36 weeks, the uterus shelves forward, and amniotic fluid embolism is possible from after the 24 weeks, in second and third trimester mostly. And in 34 to 36 weeks, the fetal head is going to be in the pelvis, and the pelvis fracture can even cause fetal head injury and skull fractures. And intestine loops are going to be pushed up, and less injury is possible in blunt trauma abdomen to the viscera. So, as we see, the stomach and the intestines are pushed up due to the gravity uterus. And if we consider the penetrating trauma of abdomen, to the upper abdomen, if penetrating trauma happens, there is more chance of injury to the viscera. And there is going to be less peritoneal signs also. So, it is away from the peritoneum, so less peritoneal signs. In blunt injury of abdomen, there is more fetal injury than that of maternal visceral injury. The signs of shock due to the trauma is going to be masked, is going to be late in pregnancy. 1200 to 1500 ml of blood loss is required to produce a sign of shock in case of pregnant ladies. And the heart rate, usually the heart rate is going to be 10 to 15 beats per minute higher than the non-pregnant state. So that can also be misleading. Regarding tachypnea, the minute volume of the pregnancy is going to be high, and there is going to be CO2 washout, and the normal PCO2 value is going to be 30 millimeters of mercury. If there is 35 to 40 millimeters of mercury of PCO2, then we have to consider the patient is an impending respiratory failure. So regarding the urine output is going to be high normally. The GFR is going to be high, the renal blood flow is going to be high, and creatinine and nitrogen is going to be less, and glycosuria is going to happen. So be careful about the signs of shock in pregnancy. And as we already told, the intestines are pushed up. The ICD we have to place at least one space above than the usual, so that we will be sure that it will be in the thoracic cavity. So about the vena cava compression, the gravity uterus and compressive vena cava, and we can improve the cardiac output by 30% by correcting the dextral rotation of the uterus. So we can achieve it by 15 to 30 degree left tilt, or 4 to 6 inches wedge we can place below the right lower lumbar region to achieve the dextral rotation correction. Now we will look at the common injuries in pregnancy. We will look at the injury to the myometrium, which is a uterine rupture. We will look at the placental injury, which is abruptio placenta. We will look at the amnion and chorion membranes, and that is a chorioamniotic membrane rupture. And fetal injuries as well. So about the uterine rupture, the myometrium is going to be an elastic tissue. So when the elasticity is gone, when it is getting ruptured, there is going to be signs, which is but rare. So tenderness is going to be there, guarding rigidity can be there, and rebound tenderness will be there, and fetal parts will be easily palpable in the abdomen, and which will be shown in the X-ray as extended limbs and all, and air foci is going to be there in the X-ray, and obviously the patient will be in shock. So treatment of uterine rupture is immediate laparotomy. We have to shift the patient immediately to the OT for laparotomy. So about the placental rupture, the placenta is a non-elastic tissue. So more chance of injury is possible for the placenta in a gravid uterus or in a advanced pregnancy stage. So regarding the abruption placenta, if you consider 70% of the cases will have vaginal bleed, that means it is a revealed one. It means that 30% of the abruption placenta can be concealed even without a vaginal bleed. So uterine tenderness, frequent uterine contractions, uterine irritability, uterine tetany, these are all going to be the signs of abruption placenta. So if we consider the placental blood vessels, they are usually dilated. They will have less vascular resistance and they will receive most 30% of the cardiac output usually. But when blood loss happens, this peripheral vascular resistance is going to be high because vasoconstriction which is happening because of blood loss. And if we start a vasopressor, that is going to be our last option because vasopressor even cause more vasoconstriction and again less fetal blood flow and less fetal oxygen supply. So regarding abruption placenta, regarding the observation of the patient, the if chance of abruption is present in post-trauma patient, then we have to observe the patient for 24 hours. If there is no risk factors associated with the placental abruption, then we can observe for 6 hours before discharging the patient safely to home. So what are the risk factors we have to consider? One is maternal heart rate more than 110 per minute and injury severity score of more than 9. Any other evidence of placental abruption? Fetal heart rate of more than 60 per minute or fetal heart rate of less than 120 per minute. Severe mechanism of injury such as ejection during the motor vehicle crash and other mechanisms of injury like pedestrian or motorcycle collision like that. Now we will look at the chorioamniotic membrane. Chorioamniotic membrane rupture is going to be one of the complications. How we can identify the chorioamniotic membrane rupture is look at the pH of the vaginal secretion. If the vaginal fluid is going to be having a pH of more than 4.5, then we can consider our chorioamniotic membrane rupture in our diagnosis. Avoid repeated vaginal examination in such cases because it is going to be more infection, chorioamnionitis, which is a dreaded infection. Maternal head injury, regarding maternal head injury, if we speak, so we have to consider an early intubation in maternal head injury. The sign is going to be seizure. Seizure is going to happen in preeclampsia. Also, can be in head injury also. So seizures in pregnancy with the trauma can be a misleading sign. So to identify the preeclampsia, we have to look at the BP. If the BP is in higher side, we have to consider the proteinuria and peripheral edema. Also, will give us a clue that whether it is a eclampsia or a per se head injury. So if we consider the intubation, then early decision to intubation has to be taken, and immediately after intubation, we have to put an nasogastric tube and relieve the gastric compression, gastric distension, because delayed gastric emptying is there in pregnancy, so that will cause more chance of aspiration. CT CT brain we can take with 25 milligray early radiation exposure. Less than 50 gray is less likely to cause any teratogenicity. So basically, we can take a CT brain. So regarding the fetal injuries, so fetal heart rate normally is going to be 120 to 160 per minute. If there is any abnormal fetal heart rate, if there is any increase or decrease either. So repetitive decelerations are going to happen, or beat to beat variability is going to be absent, or there is no acceleration in the heart rate, then we can suspect a fetal injury. So these signs we are seeing in cardiotocography. And if there is anything, then we have to consider a fetal injury as well. See, regarding the RH isoimmunization, RH immunoglobulin, we have zero point zero 0.01 ml of blood is enough to cause antibody generation in mother. So to give within 72 hours of trauma. And finally, regarding the perimortem C-section. Perimortem C-section we do in cardiac arrest due to hypovolemic shock and trauma. And we have to prepare everything in 4 minutes and we have to finish it in 5 minutes. This is a brief description of the injuries in pregnancy. There is a lot more, but I'm cutting it short to 10 minutes.